You're at the rapid fire session for building relationships to improve care for Indigenous patients and communities. Nohwe na'en jinjit show adili, drin guizi. That is Gwich'en for good day, and nice to see, good to see all of you today. My name is Cathy Almost, and I work as an engagement leader with the BC Patient Safety and Quality Council. I am Gwich'en, I am Cree, I am part of the Northwest Territory Métis Association, and I'm also Scottish. I'm an intergenerational survivor, and so pleased to be with you here this morning. I want to acknowledge the lands that Jerry did such an amazing job this morning of welcoming us to, but to the land of the Tsleil-Waututh, Musqueam, and boy, I'm just blanking here. Tsleil-Waututh, Musqueam, and Squamish. Thank you very much. And we are uninvited guests today on that land. Today we have the privilege of hearing from 3 different presenters who will proceed unannounced after the first presentation. I have the privilege of being part of the first presentation with Lee Cameron, who is a patient partner with the Patient Voices Network and also works for Northern Health as a physician quality improvement coach. And my friend Linda Nelson, who is a patient partner with the Patient Voices Network, with us today, and both are Métis as part of the wonderful experience that we're going to have today and talk about things. So this came about, this session, from 2019. I got a phone call from Hereditary Chief Bill Blackwater Jr., and he said, Cathy, I want to speak at Quality Forum. And I'm like, okay, Bill Blackwater Jr., a Hereditary Chief, Gitxsan Hereditary Chief, wants to speak at Quality Forum. How am I going to make that happen? And so I thought, who do I know who might know Bill? And I thought of Lee. And so Lee was connected to the physicians. And so we realized that Bill Blackwater Jr. had a relationship with Dr. Jaco Forey. And he knew him really well. And Bill wanted to talk about listening and the importance of listening. And so if you're interested in that session, it is recorded. And you can see that from Quality Forum 2020, the conversation between Jaco and Bill, which is a very powerful conversation about the importance of listening to understand. This is part 2 of that conversation. And we are going to have a chance to talk about listening and the importance of that. Some of you have received a handout. If you haven't received that handout and you would like to, if you want to put your hand up, Tammy is going to come around and give you a resource for those of you who haven't received it. And what this is these are principles that were created. Bill Blackwater Jr. was part of this. He was the elder, and he helped facilitate the conversation with Tammy, who's giving you the handouts. She's my director from the Patient and Public Engagement team, and with the voices of Indigenous people, including Lee and Linda. And myself, we were all part of this experience, and it was amazing because we had the chance to talk about, we had built relationships first, so we had a chance to do some relationship building and meet each other, and people were like, can you ask them this, can you ask them that, because you're getting a group of Indigenous people together, and we're very curious. And we were like, no, we want to just build relationships at that meeting. But one of the questions that came out is, can you ask what matters to patient partners in culturally safe engagements? And we were like, oh, not at this session, but we're going to have a second session for that. And this is what came out of that session. So I will let Linda and Lee take the floor.
Okay. And thank you for advancing the slides for us. And just to start off, we have nothing, none of us, we have nothing to disclose. As Cathy made reference to, the principles, and which you have in front of you, hopefully, came out of this co-design. And again, I just want to take a second to honor the late Gitxsan Hereditary Chief Bill Blackwater Jr., who passed last summer. And so looking at those key principles and knowing that they came out of this co-design, and again a shout out to Tammy Hofer and Cathy. And a huge piece of okay, and a huge piece of this, as you see with the principles and a continuity of the story that occurred last year at the Quality Forum with Bill Blackwater Jr. and Dr. Jaco Forey, is the piece around listening and the importance of that. And we're here today to speak about that. The last principle, I think it's principle 8 on listening. And I'll just shift out of the way for Linda. And so one of the things we'd like to start with is just saying, like, why was it important to you to come here today, to speak, to be here today, Linda?
Thank you. I'm grateful to be here. I was invited to Patient Voices Network by my friend Cindy Charlie Boy because she wanted me to take part in What Matters to You. And that is where I was introduced to Bill Blackwater. So I have had the privilege of meeting Bill Blackwater virtually. And I'd just like to give a little plug to What Matters to You Day, which is on June 9th. And you can participate in What Matters to You with the hashtag What Matters to You on June 9th. So the reason why, pardon me, I need to make my land acknowledgement. And I have lived my entire life on the traditional territories of the Taco-Dene in the city of Quesnel. And what that means for me is that I had the same doctor for my whole life, and for 40 years. And then he retired, and I got a new doctor. And my new doctor didn't know me. And he only knew me from my medical file. And that caused problems because there were some problems with my medical file. And that's why I'm grateful to be here today, because I want to tell you about it. And the thing about the thing is that it's not really a very happy ending of this story, but I want you to know that I am okay. So I participate in Patient Voices Network as an autistic person, and I like for people to know that I am autistic. So I do have some difficulties. Okay, a second. Thank you for your patience. I've got some notes here I need to sum up on my phone. So I was in an accident when I was working in Fort St. John. I was struck by a vehicle and lifted me up, and it put me down, and I kept working, and then a couple of days later I was in hospital having surgery. And the details of the accident would take too long for me to explain. But the point of it is that 5 years later, I'd had 7 surgeries, and I had still had pain, and I still had problems, because one of the things that happened from the accident was that my autism devolved, so I was less capable than I had been before the accident. So I had to kind of learn some neurodivergent things that I didn't have to learn before, pardon me. But so that added to the communication problem with my doctor. And he came to our meetings with a preconceived idea, because when I was in the accident and I had my WorkSafe BC, they're called now, claim go in front of the WorkSafe BC board, my boss told them that I hadn't been at work that day, and that I had been drunk and didn't show up for work, and they believed her, and they sent a letter that went into my file that said that I had been denied my claim because I had lied, and that I was dishonest. And so that stayed in my claim because, it stayed in my medical file. And the reason why it does that is because when you have a WorkSafe BC claim, WorkSafe BC pays your medical bills. So my doctor had to resubmit all my medical bills to MSP so that he would be paid. So then he read the letter. I myself have never read the letter. So I apologize, because I'm only assuming what I think he knew. Mm-hmm. But my experience was that he didn't listen to me. It didn't matter what I said to him. Every time I talked about the accident, he just went blank. So,
This was a new physician as well, who
yeah.
didn't have relationship with you from the
Yes.
And this was a new physician, not your long-term physician that you'd built a relationship. So you're moving into this place with a new caretaker. You've never
Yeah, he didn't know me.
you.
He
Was
didn't know
going
me.
by-
So he was only reading from the file, and the file said that I had lied, and I had tried to get money for an accident that never happened. And that's the important part here. The important part is that that letter created a belief that the accident had never happened. And I just couldn't get through to him that the accident had happened and that I didn't care about the money, but the accident had really happened. So there was a day when I said, I am defeating myself by talking about this accident, but I'm not going to give up. I'm going to go back to the doctor and I'm just going to talk about my pain because I still have pain. And so
that was a new way of looking at it. That was a new approach that you were taking. And what was that? Like, how did that work out?
I went back, right? I went back, and I already didn't have a very great relationship with him because, it wasn't going good, guys. And so I went back and I said, I'm here today because I want you to know that I still have pain, whether or not, I didn't say that part, but whether or not you believe I have the accident, okay? I didn't say that. But I thought it. So I said, I still have pain. I said, I have pain in my arm. I have pain in my leg. I said, I don't know what kind of things you can do to help me, but, I need some help. And it was, as soon as I said pain, I could see it come over his face, like he had put on a new mask, and I could see his training come out. And all of a sudden, I was dealing with a person who thought I was trying to get drugs because he still had the stigma or the bias that I was a dishonest person, right? So now by changing my story, now it just looked, I don't know what it looked like, but what I was getting out of him was the training that people receive for drug-seeking behaviors. So I was again blocked. And then I got upset.
Yeah.
I got upset. And I started to cry.
Understandably.
And I said, I've done everything you asked me to do. And he said, I can't tolerate this behavior, Linda. I can't have you sitting in my office yelling at me and crying. I didn't yell at him. I just said, I now didn't say anything at this point. I was just listening. And I said, I'm not yelling. I just need some support. And he said, I can't have you coming in here and yelling at me and making me feel unsafe. He said, this is the last time I'm going to see you. I won't see you anymore. You need to find another doctor. I don't want you to come back anymore.
And so there you are, you're sitting in a place where you go, you're in pain, you're frustrated, you've tried a new approach, planning to communicate in a way for this health professional to listen to you, and it didn't work. What?
I didn't know that it was reasonable to expect that my doctor would work with me to come up with a treatment plan. I've learned that through my involvement with Patient Voices Network. It is reasonable for a person to expect that their doctor will listen to them and their healthcare provider will help them come up with a treatment plan. And I honestly didn't know that. I didn't know that was a reasonable request. So that was 4 years ago. And as I'm sure many of you are aware, it is not that simple to just get a new doctor. It's complicated to get a new doctor. And I honestly don't even know how how to do it because I don't know how to do it.
And you know, Linda, another thing that you mentioned before when we were chatting was around, and then when you say you do get a new care provider, so you do get a new family doctor, what does that look like? And again, the impact of if that physician will be able to hold that space in a way to you and truly listen and to provide that, you know.
So I can only say that I came away believing that my doctor thought I was a liar. I came away believing that my doctor thought that I was a dishonest scammer. I came away thinking that my doctor thought that I was a drug user and a drunk. I came away thinking that my doctor thought that I was lying to get drugs and that I was lying about my pain. Because there was nothing I could do about what WorkSafe BC had told him.
If you could say one thing to the health professionals that are in the room who've clearly chosen to be here today about listening, what would it be?
Well, what I wanted to say is that I do know that if my doctor had asked me what mattered to me, I would have told him that the most important thing for me was getting better. Mm-hmm. And that I would do anything to have that. But because of whatever reason that was keeping him from hearing me and thinking about what I was telling him, I didn't get any treatment. And so that is why I'm so grateful for you to listen to me today. Because listening can get in the way, not listening can get in the way of people telling somebody what they need. And everybody has the right to work with their doctor to have a treatment plan, but not everybody knows that. So I guess that an active listening role for a healthcare provider includes making sure that a patient is informed that they have the right and the responsibility to participate in the development of a treatment plan.
Thank you. Thank you for sharing your heart.
Thank you so much for listening to me today.
We do have time for a question. Does anybody have any questions for Linda or Lee? Just wait till the microphone comes, please.
Thank you very much for that. I'm with Métis Nation, British Columbia, and I understand from your intro that you are also Métis.
Yes, sir.
Have you contacted the regional health coordinator for that region to help you navigate this? The young woman's name is Katina Pollard, and it's her job to help people like yourself navigate through the healthcare system and get to the appropriate level of care that you need. So afterwards, if we want to talk, I can give you her phone number.
Thank you. I appreciate that information.
You're welcome.
Not a question, just a comment. I just want to say thank you so much for sharing your story. It's really touching, and I'm so sorry for that experience. No one should have to experience that. And I'm just very moved by it, and thank you.
Thank you. Thank you, everybody, for listening to my story. I know that it is not easy to listen to sad stories, and I'm grateful for you because by sharing my story, I feel like I have lifted a weight from myself.
Good morning, everyone. Just wanted to thank Linda for that powerful message. As someone who's trying to become a physician here, I think it's a very important message to share. I'm presenting my quality improvement initiative from Kílala Lelum Health Center, entitled No One Left Behind. My name is Wajid Khan. It's nice to be here. Nothing to disclose. I'd like to begin by acknowledging that we are all here on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh people. So I work at Kílala Lelum. It's the medical center in the downtown east side. We started in 2018 with over 80 staff, nurses, doctors, outreach workers, social workers, and sorry. We serve over 1,300 patients, 70% of whom are Indigenous. So a little bit of a background about my project here. We know that the Indigenous in Canada are disproportionately affected by COVID-19. According to the First Nations Health Authority, Indigenous people test positive at a higher rate and also have higher ICU admissions as well as deaths compared with other ethnicities in Canada. And this is sort of compounded in the downtown east side where, if you don't know, there's a lot of poverty, homelessness, compromised immunity. And so the problem really is that in the downtown east side, what we have is higher risk for COVID-19 and COVID-19 complications. And so our goal really was to minimize the transmission of COVID-19 in the downtown east side and by optimizing access to vaccination. And we feel this was in line with the Truth and Reconciliation Call to Action number 19. And so how we set out to achieve this goal, we had two objectives. Number one, we wanted to vaccinate over 95% of our patients. And secondly, we wanted to engage in dialogue those who were hesitant to receive vaccinations. The way we did this, first of all, we needed to get a baseline for our patients. As I said, we have over 1,000 patients in our clinic. We wanted to know who was unvaccinated. We used Care Connect. If you're familiar with that, it's a database where we have everybody in BC whose health information can be looked up, and we found out through there who was unvaccinated. From there, we had our MOAs in our clinic call those unvaccinated individuals. And to monitor the progress of our vaccination, we created like a chart, which I'll show you in a bit. So I said before, one of our main tools was Care Connect. So we used that to sort of obtain vaccination statuses for all of our patients. We also inputted this data into our EMR, which we used Oscar for that. And then from Oscar, we sort of extracted an Excel database of everybody's vaccination status, which the MOAs could use to make calls to all the unvaccinated individuals. This is our chart. This shows our progress. This plots the percentage of patients on the y-axis over time. So this is 1 year of progress. You can see the blue line represents those who had one or more shots. The orange represents those who were unvaccinated. Green is fully vaccinated, and yellow is just one shot. So last July, we obtained vaccination statuses for 901 individuals. So that's our baseline. We had only 30% of our patients fully vaccinated. 54% had one or more shots, and 45% were unvaccinated. So this was last July. And you see this high number of almost half of our patients were unvaccinated. Over the year, we sort of made steady progress, and we sort of accounted for the fact that eligibilities also changed. So when the eligibility changed to 12 and up, we included those patients, and when the eligibility changed to 5 and up, we also included those patients. As of May this year, that's our progress. We're looking at over 1,000 of our patients there, 76% of who have one or more shots, and 66% who are fully. 66% of our patients in our clinic are fully vaccinated now, as of May. When we compare our data from our clinic to the rest of the country, you see we do fall short there. 90% of almost 90% Canadians and over 90% of British Columbians are now fully vaccinated compared to us. And so just want to talk a little bit about what kinds of things we did to bump up our vaccination rate. We used our EMR quite extensively to create patient chart alerts so that the MOAs would know who's unvaccinated. We also sort of sent messages and emails to care providers letting them know who needs their shot, gave them physical hard copies of patients who needed their shots, recruited outreach workers. We have a great outreach system at our clinic, and we would request them to go and see these unvaccinated individuals, engage them in dialogue. As well, we had a lot of pop-up clinics in the downtown east side, so we would refer patients there. As you can imagine, working in the downtown east side does have its challenges. We had, of course, our clinic is quite busy, and we didn't always have the time to sort of call hundreds and hundreds of unvaccinated members. And so that was one of the challenges we had. We also had vaccine shortages in the downtown east side. Our clinic our clinic was always in short supply. We'd had to obtain the vaccines from another clinic as well. Our nurses also were quite busy and could only vaccinate a set number of people a day. Furthermore, we had a lot of patient barriers as well. One of the big ones is, of course, vaccine hesitancy due to mistrust. I'll expand a little bit more on that. As well, transportation. Not everyone had easy access to transportation in the downtown east side. Health challenges such as being immunocompromised, and one of the major ones in our clinic is that patients were sort of difficult to connect with. There's a lot of homelessness in the downtown east side, so patients don't always have phone numbers that we can reach. They don't always have personal health numbers we can use to look their information up. And all of these sort of barriers they stem from bigger barriers in the downtown east side, where we have a lot of poverty, homelessness, a mental health crisis, and a worsening opioid crisis. If you've been following that, it got worse over the pandemic. I just wanted to expand a bit about the vaccine hesitancy. We know that in the Indigenous population, it's important to acknowledge the historical context of this hesitancy. We know that there's been a lot of exploitation, a lot of experimentation. There's numerous examples. The one I've listed here are just few of the many, such as nutrition experiments in communities in Manitoba, testing of the BCG tuberculosis vaccine, experimental drugs and surgical procedures done in Indian hospitals, residential schools, a lot of those without consent. And so this is really important to acknowledge, and I guess, I feel that the message I really want to convey is that when you're working with the Indigenous, and in particular during the pandemic when you're trying to vaccinate an Indigenous community, it's important to really have credibility and trust in that community. And I feel our clinic did accomplish that. We have Indigenous elders and Indigenous healthcare workers that have for years established trust in their community, and it's one of the reasons we were able to get a vaccination rate as high as we did, even though in conclusion we weren't able to reach that 95% goal that I was mentioned in the beginning. We fell short. We still think this is meaningful, worthwhile work to continue. The downtown east side always needs more resources and more of this kind of work, and we are continuing efforts. We're still trying to reach that goal, and we are trying to come up with new ideas to sort of move forward. One of the things we were discussing recently is maybe providing incentives for those people who are hesitant to receive their vaccination, something like a gift card. We were also thinking of maybe connecting those patients who are hesitant with elders and maybe clear up any sort of barriers that they had with respect to vaccination. So just wanted to acknowledge Dr. David too. He's the supervising family doctor on this project. He can be here today, but he's very highly respected, and he works. He's done great things for the Indigenous community in the downtown east side. I highly recommend you look him up afterwards. I'd also like to thank the nurses, MOAs, and the elders of Kílala, Lelum. Thank you very much. Does anybody have any questions for me? Yes. Okay.
First of all, what does EMR stand for?
Oh, electronic medical records. So that's just our software that we use in the clinic to look up our patients, all the patient records on the computer.
Okay, I just wasn't sure what the acronym was.
Oh, I apologize. Sorry.
Yeah, the other thing is that when you were talking about residential school survivors having medical experiments done on them, my husband was actually one of those. He was in Alberni and had medical experiments done on him that we're trying to find out what it is. So the other thing I wanted to talk about is you said people who are hesitant to have shots can talk to the elders, but a lot of the people that were in residential school are the elders.
Yes.
So, you know, it's, I mean, my husband has had all four of his vaccines. So, you know, he's not hesitant, but I know that a lot of people are, and it's really tough. But I wanted to say thank you for your talk today. I really appreciated it. So thank you.
Thank you. Thank you. It was a pleasure.
Thank you for your presentation. So, I guess being a nurse who's worked in a northern community where it's always difficult to sometimes reach clients because they don't have access to a phone, or maybe, you know, they're living in a bush, like in a cabin. You said your process of getting clients to come in was contacting them via phone. And I found sometimes the most vulnerable are those who don't have access to a phone or computer or whatever. What was your method for contacting, I guess, for getting those people to come in to get vaccinated?
Thank you. Great question. Yeah, so oftentimes a lot of our patients we weren't able to contact. One of the things we tried to do was we have outreach workers at our clinic that go to the homes of the individuals or try to find these individuals. We also don't have addresses for some of them. A number of them are homeless, and so it often takes sort of experience working in that community to know where you would find such an individual. And to answer your question, I think sometimes you do have to go and visit and sort of leave your clinic really and have to be able to engage people.
Okay, so the outreach workers, okay. Because
Yeah.
I was wondering if that impacted you. You had a goal of 90% and you're not able to achieve it. So I was wondering if it was because, you know, you were not able to access some clients because they didn't have phone numbers, so it's hard to reach them.
Yeah, that's partially one of the reasons. There were also a subset that we were able to reach, and just circumstances prevented them from coming out. You know, we would book them for their appointments, and sometimes they would forget to attend their appointments. Other times, health complications. So, you know, it wasn't just sort of one challenge. There was multifactorial. But, you know, we try to figure out ways around those.
My question is it even possible to vaccinate somebody without a personal health number?
So actually, we weren't able to even reach those individuals. If they didn't have a personal health number, I could not look up their status, and therefore I did not know where they were vaccinated or not vaccinated. For my project here, we only considered those who had personal health numbers. But had I been able to connect with someone without a personal health number, I would have definitely at least had a conversation around vaccination.
Good morning. Thank you for the presentation. I come from the Prince George region of the Carrier Nation, and what the strategy that we had was we videotaped in our language, and we had subtitles as well to explain everything about the vaccination. And so we reached out as much as we can through videotaping ourselves. I speak my language fluently, so that was a huge help for some of our elders that still have the language. So thank you.
Oh, thank you for coming here all the way from Prince George. Yeah, I hadn't considered that idea, actually. We have a diverse group of Indigenous clients at our clinic. I think that would be an excellent idea to implement. Okay.
Hi, thank you for your presentation. My name is Bhavna. I work with the First Nations Health Authority as an immunization educator for nurses, and we were involved in the the COVID vaccine promotion strategy through First Nations Health Authority. Something that we found was really powerful was there was talk about should we incentivize vaccines? How can we gain support for the vaccine, and the idea that came through was really highlighting the stories of those that did get their vaccine, and ask them why they were vaccinated, what prompted them to take this step. And so a lot of conversation about protecting community, protecting those around them came forward, and further sharing those stories was a really powerful incentive. So over monetary incentives or gift cards, we found that those stories became really powerful. And so there is a portal, if anybody is interested. It's called Vax Champs on FNHA's website. And so you can see pictures of people, kids and elders that were vaccinated, sharing their stories. And I thought maybe, some posters of folks that came to your clinic and did get, the full series of the vaccine, just having their stories, maybe that would also contribute to some vaccine acceptance in the downtown east side. Thank you for all your work.
Thank you for that suggestion. That's an excellent suggestion. Yeah, we were a little bit unsure about the whole incentivization process as well. But I really love your suggestion, and I will definitely check that out on the FNHA website. Thank you.
Thank you. How's the volume? Good? Okay. Okay. Hello there. My name is Alex Kent. I am a fifth-generation settler of British and Dutch ancestry, and I'm currently residing on the ancestral territories of Syilx Nation of the Okanagan Nation Alliance. I'm also a PhD candidate in Simon Fraser University's Faculty of Health Sciences, and today I'm here representing the Kwiis-hen-niip project as the project manager. Unfortunately, my co-presenter, Nicole Malcomson, is unable to attend, but I'm lucky to have our project lead, Dr. Jim Christensen, in the audience, so if there's any complicated questions, I'll be sure to redirect them to him. And today, I'll be sharing promising practices for co-designing and implementing community-driven first responder care improvements in remote Indigenous communities. Kwiis-hen-niip, which is a Nuu-chah-nulth word for change, is a research study, and it represents a nation-led partnership with Nuu-chah-nulth Tribal Council, First Nations Health Authority, Island Health, BC Emergency Medicine Network, UBC Department of Emergency Medicine, and BC Emergency Health Services. We are also partnered with Út-uishtikiw Society of Traditional Healers, who provide guidance on topics related to Nuu-chah-nulth traditional healing. Like the other speakers, I'd like to take this moment to gratefully acknowledge the unceded and ancestral territories of Musqueam, Squamish, and Tsleil-Waututh nations, and also acknowledge the privilege I have of getting to work with Nuu-chah-nulth, who are a group of 14 First Nations on the Pacific Northwest coast. Kwiis-hen-niip is partnering with 4 Nuu-chah-nulth nations: Kayukit-Checklissit, Heshquiet, Ahousit, and Cloquiet, pictured here. I also want to acknowledge the tremendous leadership of Nuu-chah-nulth Tribal Council, who have extensive research experience and have led numerous studies and initiatives over the years. Just give me one moment. There are persisting gaps and fragmentation of emergency medicine and first responder care in remote Indigenous communities who have been excluded from the urban centralized design of health systems. Kwiis-hen-niip builds on a prior needs assessment conducted in 2018 and 2019 that involved an in-depth consultation process with Nuu-chah-nulth community members, local first responders, community leaders, nurses, physicians, elders, traditional healers, and external agencies. The illustration is a graphic recording that resulted from one of the community dialogues. Priorities identified are addressed in the next slide. Through this process of community engagement, we co-defined 6 priority areas for emergency care improvement. First responder support and sustainability is aimed at enhancing support for first responders through access to real-time virtual support and post-incident debriefing. We are working with partners to develop a training and ongoing support model for first responders to increase recruitment, retention, and job satisfaction. Training will be developed and delivered in a culturally safe way and include culturally relevant content. To address patient transport, our team will work with BC EHS and the Coast Guard to clarify and improve the chains of communication to authorize transport, increase availability and safety of transport, and if and when necessary, redefine hospital referral patterns. We will examine strategies to improve cultural safety and reduce racial bias during the process of patient transfer from remote communities to hospitals. Under the theme of communication, we have already begun discussions with TELUS related to accelerating plans for effective and consistent high-speed internet and cell service in the 4 communities. This will enhance emergency care and assistance for first responders. For community readiness, first aid and CPR training will be implemented in high schools, and a custom educational campaign will be rolled out in each of the communities. Primary care was added as an additional theme because the other priorities must be viewed in the context of nursing and physician support. As we work to enhance emergency care, we anticipate that primary care, whether that be in community or using telehealth, will be enhanced such that first responders, nurses, and physicians can work as a coordinated team of emergency care providers. Finally, cultural safety and anti-racism were also identified as key overarching themes. The Kwiis-hen-niip team is committed to ensuring the project is in alignment with and accountable to Nuu-chah-nulth values, protocols, and ethics. In addition to wider reports and calls to action, including but not limited to RCAP, TRC, OCAP, TCPS2, UNDRIP, In Plain Sight, and Missing and Murdered Indigenous Women and Girls. The team is now designing a package of interventions within the 6 priority areas. Already, we have many successes to celebrate. We recruited and hired first responder coordinators in the 4 nations who are assisting with tracking community callouts, identifying key training and equipment needs, and being a community voice for the Kwiis-hen-niip project priorities. We've also facilitated a partnership with real-time virtual support, that is RTVS, to make rural urgent doctor and aid, or RUDI, available to first responders. We are facilitating ongoing communication between Nuu-chah-nulth first responders and RUDI doctors through monthly virtual dialogue sessions and asynchronous Facebook engagement. We are co-developing a first responders programming guide and a template for first responder case reporting. We've also collaborated with First Nations Health Authority and North Island College to coordinate first responder training in Campbell River, Port Hardy, and Tofino. Furthermore, with the support of Heart and Stroke Foundation, just last month we finished filming a CPR training video, which is outstanding, and it reflects the Nuu-chah-nulth people, places, language, and worldviews. So it's the first of its kind to do so. I want to acknowledge, partly for Jim's sake, that this image is not supposed to be legible. It's simply to demonstrate complexity. So each nation has unique strengths and assets, but also experience unique barriers and challenges that shape the design and uptake of interventions to improve emergency care. Some of the variables across communities include differences in first responder call-out processes, such as that which is illustrated. This is just one nation's call-out process, and it differs in each one. Also, availability of nurses and physician support within community, proximity to hospitals, clinics, or nursing outposts, transportation options. For instance, in some of these nations, it's only fly-in or boat-in only. Connectivity, so there are differences in cell reception, quality of Wi-Fi. Some nations simply rely on radios to get a hold of one another. And of course, demographics affecting recruitment and retention of first responders. However, it's important to note that all the nations have very strong leadership within their first responder teams, as well as community and cultural leaders who are supporting the first responders in the work that they do. Our team's approach to navigating these community-specific complexities includes engaging in meaningful consultation and embedding community representatives in our investigative team for constant and ongoing feedback on our work. We also respond to community needs, centering local priorities and co-design solutions at the community level. And of course, we are flexible and adaptable, addressing complications as they arise. Our next steps involve first continuing to co-design emergency care improvements. This is followed by implementing these changes in each of the 4 nations. And throughout this process, we'll be evaluating the emergency care improvements using a mixed methods approach and informed by implementation science. We are committed to sustaining these implemented improvements with the support from our network of partners. And finally, our aim is to develop an adaptable model for use by other remote Indigenous communities. Our study of the impact of the interventions we are implementing involves a mixed methods approach, which will incorporate quantitative analysis of incident reports with key informant interviews, focus groups, surveys, and ethnography. Our goal is to catalyze long-lasting improvements in emergency care that are rooted in and responsive to community experiences and values. The potential impacts of the Kwiis-hen-niip project are first and foremost to provide the 4 nations with a more effective first response system with access to remote help and rapid transportation when needed, delivered with cultural safety and community bystander support. Additionally, Kwiis-hen-niip is contributing to strengthening capacity within Nuu-chah-nulth nations to continue advancing innovative change in first responder care, nation-led research, and data sovereignty. The solutions we co-develop and the methods we employ will be transferable to improving emergency medicine and care in other remote Indigenous communities in Canada. With that, I'll just give credit to our incredible investigative team representing various academic institutions, health organizations, and governing bodies, again with key leadership from Nuu-chah-nulth Tribal Council. And during the question period, I will leave this slide, or if with permission, I'll leave the slide on if you want to jot down any contact information if you want to learn more about our project. Oh, any questions?
Thank you so much for a fantastic overview of this really important work. My name is Scott. I'm a nurse and a researcher. And I'm curious to know, as you're talking about the evaluation plan for Kwiis-hen-niip, you mentioned at the end the use of ethnography. And I won't bore the non-methodological nerds in the audience, but one thing that I just want to note is that ethnography has been really problematized as a method, especially when it's led by folks outside of the community. I wonder if you could speak a little bit to acknowledge maybe what type of ethnographic approach you're hoping to take, and how you intend to do that in a good way.
Thank you, Scott. As a researcher, I promise I didn't plant this question in the audience. So I will acknowledge the methodological expertise I bring to the project is more along the lines of implementation and integrated knowledge translation. We do have a postdoctoral fellow. Her name is Megan Muller de Silva, and she has a long-standing relationship with the Nuu-chah-nulth nations, and specifically in their Department of Health, and she's bringing background experience from medical anthropology, and so she has experience and has engaged in consultation with appropriate leaders about how ethnography is appropriately and respectfully honoring locally situated methods for knowledge sharing. And so to the extent possible, these are general research terms that I'm bringing up that are like categorizing the methodology, but we're first and foremost seeking alignment with traditional and culturally appropriate methods for knowledge exchange and knowledge sharing. I agree, ethnography and anthropology in general do have a bit of a toxic history. I mean, as does all research, and we heard about Indian hospitals, and Nuu-chah-nulth in particular does have a history of really bad research practices in the nation or in the territories. And so we are mindful of that, and we often reflect on that, and we're deliberate about centering OCAP principles.
Any other questions?
Getting off easy. Thank you.
Well, thank you so much, everyone, for attending. And you can feel free to fill out a paper evaluation if you would like, or you could do it online. And we have the gift of a couple minutes to get to your next session. So thanks so much.